Hello guys, directly from home. I just arrived from work, taking some time to try to give you some ideas and to talk tonight about which observership to choose between all the alternatives you have available. And I'm very sorry that most of the people that are providing these virtual observerships or in-person observerships in the states that are allowing for observerships have these very hefty fees. Um, it's just incredible how they keep saying that they're helping international medical graduates by giving you an opportunity to shadow someone for $3,000. That's crazy. But sometimes we have to do what we have to do to get into the position of being a physician. So I will recommend you that do an effort, talk to your family, talk to your friends, get a loan. Once you get it, once you get in, you will be able to pay any loans. It seems like a big risk, but with faith and with the effort that you will put on your application, you will get in there and you will be able to pay any loan. So go ahead, get a $3,000 loan and get your observership. Um, it's scary, it's a big risk, but you will be able to pay it. So it will pay on its own over time. So which observership to take? This is for you to think. A lot of people try to take only the internal medicine rotation observership, whereas it is smart to do that because usually you will be working along residents and you will get a letter of recommendation from the people that you have been working with, either if this is in person or if this is a virtual observership that is telling you that they're going to give you a letter of recommendation. All good. But there are other opportunities around there and maybe cheaper. Like you can find a palliative care um, observation rotation, like at a cancer center. You could find a rehabilitation medicine rotation. You could do an infectious disease rotation. You can do an endocrinology rotation. You can do a family medicine rotation. And you can even do a trauma surgery rotation or a surgery rotation. What you what you have to keep in mind is that all the rotations that you will do will show on your CV, and this will be a point of conversation with your interviewer and you. So usually what we do is we go through everything on the CV, not to prove that you're not worthy of an internal medicine residency spot because you did a rotation on anesthesiology. No, we we're trying to get to know you. So what is important is not just what you did, but what you learn from it and how you present it in our conversation. So, for instance, an applicant that is going to do internal medicine residency needs to know all the other specialties: cardiology, endocrinology, infectious disease, dermatology, trauma. Why? Because as an internist, you are basically the general practice doctor inside the hospital. And there are areas or diseases that you don't know about. Let's say there's a myxedema coma coming to your hands on admission. The ER doc stabilized this patient and is given to you. So you, as the director of the cruise, choose who to call. Now I'm going to call endocrinology, but endocrinology won't be here until tomorrow morning. So I need to know the basics of the endocrine management to stabilize this patient and make him survive until the endocrinologist comes in the morning. Same with trauma surgery. Trauma is a specific and very important rotation you get your hands on, because trauma is acute management, life-saving management, and as an internist, there's so much to learn from them. Not only rapid placement of central lines, ultrasound, fast ultrasound, evaluation of the polytraumatized patient, but life-saving measures. And also, trauma doctors on facilities or hospitals that are trauma centers, trauma doctors consult the internal medicine crew to manage hypertension, diabetes. If there is a concern for DIC, call the internist. He's going to tell us what to do. Call the internist to restart this patient on his home meds, because they don't do that part, and they get scared with a hemoglobin A1C of 9 or a glucose level of 250. They think, oh, DKA, and it's not something that they do very often. So there is so many ways to enrich your experience from all these rotations. I would suggest trying to look on the infectious disease, because we consult infectious disease for everything. Everything that needs to be ruled out, we consult infectious disease. We consult endocrinology. Very important to know the basics of mixed edema, hyperthyroidism storm, adrenal insufficiency. No one knows what to do with adrenal insufficiency. We know we have to order the ACTH stimulation test, but we don't know how to interpret the results. We always call the endocrinologist for that. It's crazy, but it's the truth. So you coming to us saying that you know all this, it will be very impressive that you explain in the right words why you did such rotation. And it's always the intent of me taking the rotation was to fortify or to solidify the knowledge or my preparation to start an internal medicine rotation. I'm very good at the bread and butter cases of chest pain, stroke rule out, abdominal pain, small bowel obstruction, but I'm not very good at endocrinology management. And I think that after the rotations, I got a little more confident on the acute management of these emergencies that don't present very often, but when they do, it might catch us by surprise. And then another one that's good is neurology. If you can do neurology, you will be good. Neurology, we consult them all the time for rule out CVA, for new onset seizures, for breast syndrome, from Hispanic panic. Hispanic panic is always rule out CVA, and it always turns out to be it was just a panic attack. What else? I was thinking about one that is, well, palliative care, because you will not believe that the first year residents are not ready to have a conversation on determination of goals of care. I keep saying the same, guys. If you know how to do a conversation for goals of care determination, how to talk to a family into the best course of action for a person that has very poor prognosis is to do inpatient hospice or to transfer home on home hospice, you will be in great shape for residency, for on your own. It's not something that many people know how to do. And internists or program directors love this, love when there is a person skilled enough to have this conversation, because to convince someone to start hospice care, to convince someone that this is the best treatment, you not only have to be a people's person, you have to be empathetic, you have to be able to explain a disease process in a way that the family will understand and believe that this is the right treatment, this is the right option for their family members. It's an art, but it's an art based on science. What is rehabilitation? Rehabilitation, very important. Why? Every patient that we have to discharge for medical, legal purposes, we have to have a physical therapy evaluation, or at least mentioning on the discharge summary that you were able to ambulate this patient and that he was able to sit to the edge of the bed on his own without assistance, to stand, to start taking steps, to demonstrate that their balance is proper to be at home alone. Because if you don't document that and you send a patient home that would have needed physical therapy, you send them home without physical therapy or without referral to a skilled nursing facility, the family can sue you. But they won't sue a resident, they will sue the attending. An attending doesn't want to be sued. Remember that in residency, you should be already acting as an attending. We don't want people that are coming here to learn the basics. And that's the problem with international medical graduates. Most of them are very young, not mature enough, and coming to learn, coming thinking that residency is to learn the basics. And those residents are in the eye for remediation. Why? Because they are not working head to head with the American ones, with the ones that are more prepared. So you have to, if you're applying to internal medicine or family practice, you have to get to know all around it. And basically that is that you have to get to know all the other specialties, at least a little bit of all the other specialties to do a good management of your patients. So those are my recommendations on this topic. If you get your hands on any rotation, get the cheapest one, go for it, learn as much as you can, find the angle on how this will benefit your application to internal medicine, because it will. You can send me an email and ask me, and I will tell you how will this benefit you. And good luck, guys. Remember, study as hard as you can at nighttime. Watch some videos about what's residency life, and then keep studying, do your best, and you will get there. And we will see each other in one of these internal medicine conferences once a year at some point. Okay, bye.